joining us on this webinar. So just a few housekeeping rules. As I was saying earlier, one, please switch off your video feeds. Second, please switch off your microphones so that we are a lot more clearer. There's no, ambient noise in the background. Second is we will start recording the session, and right away the session will be on YouTube right after for those who want to continue to watch it again and pick up some points, as well as to share to everyone else who's not been able to join us this morning due to work and other concerns. So the Malaysian Medical Association has very kindly consented to approve CME points for today. I think we'll give a total of 2 points. So as you know, I have sent the email out to everyone in which you have the link for you to key in the points for your attendance, and the points will be credited to your CPD account. Now, in order to do that for the medical doctors, as you all know, there's 2 code words that we will share during this session. So please pay attention. Don't worry, they won't be secret or something. I'll announce and tell you what are the code words, and then make sure you key them in so that proves that you actually attended and actually listened to the presentation. So we're going to just start on the presentation already. So this is the first kind of kick-off of the Dr. SK Dharmalingam Lecture Series. So Dr. SK Dharmalingam was our founder of the National Cancer Society of Malaysia, and I think one of the really good things that we have is people like Dr. Chandra and Dr. Khanna over at Nilai, who've actually worked with Dato previously in his time together with us. And one of the big challenges that we know is going to come due to COVID is the fact that a lot of patients are behind on their cancer treatments. People who are having symptoms are not very clear whether they are getting screening or not. Some of them are very scared to come for treatment. And one of the big challenges is we see a lot of people who are actually concerned on whether we should do chemotherapy during this time, we should do radiotherapy for this time. And that really is part of why the series has come about. It's to educate and to share with a lot of us frontliners, the family physicians, the general practitioners, as well as other clinicians and patient advocates on information pertaining to relevant aspects of cancer care. And I think one of the main important points of cancer management today is radiotherapy. And there's a lot of concerns about radiotherapy. Some of them actually most of them are unfounded. Some of them need to be addressed. And very generally, I think a lot of people have, we could have a much better understanding of radiotherapy. So together with us this morning, we have been very privileged to have Dr. Chandrashekar Hospet. Dr. Chandra is a consultant clinical oncologist who's currently attached to Nilai Medical Centre. So for those of y'all who are not aware of Dr. Chandra, who's really almost one of the mainstays of oncology management in Malaysia over the many years that he has been with us, Dr. Chandra has served in various capacities in Manipal and together as a clinical oncologist in Hospital University Kebangsaan Malaysia, as well as in numerous other institutions. Dr. Chandra is very actively involved in clinical research. He publishes quite a bit, both internationally and nationally, and he was one of the UICC fellows in brachytherapy in the US and in Singapore. So Dr. Chandra's own interest is really in working in precision radiotherapy, and he has been with Nilai Medical Centre since 2006. And actually quite a lot of our current set of oncologists and all that have benefited from Dr. Chandra's experience and expertise and his insights in helping us manage the disease in Malaysia. So today, Dr. Chandra has kindly consented to speak to us about radiotherapy in the time of COVID. So without further ado, ladies and gentlemen, please allow me to turn the session over to Dr. Chandra. Doctor, it's all yours.
Yeah. Hi, good morning. First, at the outset, I must thank National Cancer Society Malaysia for giving us an opportunity to talk a bit about very concerning topic of cancer care, particularly with regard to radiation therapy, because the radiation therapy is not a one-day treatment. It is stretched over a period of 2 weeks, and the patients have a concern to continue or to come forward for the treatment or not. There are so many ifs and buts in the patient's mind as well as the family and then the caregivers. So I thought I will just little bit touch upon this important issue and share a little bit of my knowledge and understanding of how to overcome and then how best we can continue treatment for a certain group of patients. So this is a very critical time when continuing a cancer care. Even systemic treatment like chemotherapy, going for surgery, and radiation therapy, all will have an impact on the patient's outcome if delayed unduly, or if proper measures are not taken while handling the patients. We thought we'll just address a bit of this issue and then talk and then discuss a little bit, and then any suggestions also are welcome, because everybody is going through an evolution of understanding how to manage the patients. Okay, so we start the presenter. Before we start talking about the cancer care and the radiation therapy during the COVID-19, for the benefit of the doctors assembled here who are not currently or actively involved in the core care of the cancer patients, just want to let them know what is radiotherapy. A brief introduction for those who want to understand a little bit more. So the radiotherapy is actually an intense energy of radiation beams. So the currently worldwide type of radiation beams which are used are basically the X-rays, or they are called as photons as well. These are very high energy diagnostic radiology. So diagnostic radiology, they uses the kilo voltage beam, whereas we use the mega voltage beam to kill the cancer cells. So here the target is basically the cells, within the cells, the DNA. So these DNAs are damaged beyond the repairing capacity. And then when the cell tries to divide, and then they die. Okay, so that's how the radiation works. Its basic thing is attacking the DNA, making the cell incompetent to multiply and then continue growing. Okay, and then it is, the treatment is stretched over a period of few weeks. It's given in small fractions, which lasts about, usually radical treatment 4 to 6, 7 weeks, and then palliative treatment maybe about 1 to 2 weeks. Okay, and then when the cells are affected by this radiation, so the cells immediately won't die sometimes, unless they are in a mitotic phase. So these cells will carry the damage, and then when they try to divide, then they die. That's why sometimes you see the radiation effect can continue to be exhibited in a patient over a period of time, even after completion of the treatment, maybe about weeks or even little longer as well. Okay, so that's how the radiation works. So it's a local or loco-regional type of treatment. It's not a systemic treatment like chemotherapy, immunotherapy, or hormonal therapy. This is something similar to the surgery, where it can be focused and then treated to a local area or loco-regional area. So what I mean by loco-regional is the draining lymph nodal stations also can be treated, encompassed within the radiation field. Okay, so like I said, most often we use the X-rays. Even particle radiations also can be used, like electrons, to boost the tumor bearing area after you covering the probable tumor bearing area and then the primary tumor. The electrons can be focused, and then you can boost the dose to that area. And other types of particle radiations like protons, so many other things like heavy ion and carbon beams. There are so many particle radiations which are coming up and which are quite expensive to install and then start the treatment at this point of time. But I hope in future we are going to have more and more units and treatment becomes affordable. Okay, but they are very precise, very limited number of centers available worldwide. Okay, so when it comes to the radiation therapy, how we deliver the radiation therapy, to the cancer patients is by basically two means. One is from the external beam radiation, means like you can see in this picture here, the machine which is shown here is the linear accelerator machine which can rotate 360 degrees, and then here is the patient lying on the couch. You can adjust the patient's body part which has to be irradiated, and then you focus the radiation to that particular area and then treat. This is the linear accelerator. The beam is coming from the head part of it, the one here. So this is the window from where the radiation comes out and then hits the patients of a desired particular area or the part or the organ we want to treat. So this is how the external beam radiation is delivered. Patient is untouched, patient lies on the couch, and then you won't experience that he is getting the radiation. It's just the rays which enter the body. No pain, no feeling, doesn't feel any discomfort at this point of time. And another type of treatment is brachytherapy, otherwise also called as the internal radiation. What is this brachytherapy is? Instead of giving the radiation from outside, what we do is we keep the radiation sources within the tumor or on the surface of the tumor or within the body and irradiate that particular areas. So this is a machine which is a quite a simple looking machine, but it has a radiation source secured here with all protective measures, and then this machine is remotely operated, and then when everything is ready, the applicators are inserted and then imaging is done and then the planning is done, all ready to go for the treatment. Then what we do is from this machine we have got a channels, multiple channels depending on the number of applicators you have used. So you use the number of channels which is predetermined during the planning, and these channels through the transfer tubes are connected to the applicators. Like this is the case of CA breast, it is undergoing the accelerated partial breast irradiation. So the applicators are inserted and secured into the place of area of your interest to be irradiated, and then these transfer tubes connect the machine to the applicators. And all the once you operate from remotely, the source from this machine will travel through the transfer tubes and goes to the particular applicator as designed during the planning time, and go and sit there and irradiate for a particular period of time, delivering a predetermined radiation dose to that particular area. And this is a very localized treatment, highly confirmed, and it doesn't give much radiation to the surrounding normal structures. At the same time, the tumor bearing area and then the surrounding areas which you want to irradiate, you can deliver a very, very high dose of treatment. And another advantage is this is a treatment which doesn't go on for weeks and weeks. It can be done in a very limited number of fractions, maybe about 3 fractions or 5 fractions, depending on the area you want to treat. And as you have decided the dose and then the scheduling and then the fractionation. But generally it is very short treatment, but only thing is it is an invasive procedure where you need to put the applicators into the patient's body. Okay, so that's the brachytherapy. I just show you a small video so that you can understand how the brachytherapy works.
Yep. Sorry, doctor, it doesn't seem to be playing the video.
Okay, that's just one small brief video presentation to just give you an insight into how the brachytherapy is used. The case which was showed in the video is a lung tumor, very early lung tumor, which was localized, and then you can irradiate that particular area by inserting the applicator through the endoscopic guidance, bronchoscopic guidance, and then treat that area. Okay, this is how the patient is treated. So now we are coming back to the cancer care during the COVID-19. First, we just talk about a little bit about the cancer before we touch upon the radiotherapy specifically. So this is a very challenging time for patients as well as the treating physicians. Keeping in consideration, the cancer patients already are immunocompromised by two factors. One is the disease by itself, and another one is continuing cancer care. Both also will make the patients compromised with regard to the immune status of the patient, and they are at a very high risk of developing this particular pandemic. So that will be a very challenging task for the patient as well as for the treating physicians. Okay, so this needs to be addressed and then come to a understanding how best we can continue the treatment. Why it is important to continue the cancer care is from previous experiences of analysis done by the National Cancer Database in US during the hurricane disaster. When there is a delay of the treatment for the patients, when you see at the end of when they resume treatment and complete the treatment, their overall survival was greatly compromised. So based on these previous experiences, we have learned a lesson. People are understanding to not to withhold unnecessarily wherever possible to continue the cancer care. So this becomes a reference for us to look back and then learn and then how to move about. The longer the disaster extends, then the longer there will be a risk for the patients. They may not contract the disease, and then they may not suffer from the pandemic, but their cancer may worsen and worsen, and then they may die. So that is another point which needs to be kept in mind when balancing to treat or not to treat. So a lot of patients, when they come to our clinic also, they ask, is it safe to have radiotherapy during this time, or can we hold on? How to go about it? So this is a challenging question for the patient as well as for the doctors to make a decision to proceed or hold or omit the radiation. So we'll just touch upon few of the things which has been gathered in the previous few months from most of the centers who are treating the cancer patients, and what is their experience. Very limited data is available, but with limited data we can make some decisions and then move forward. Especially when you are talking about the systemic treatment and surgery, so it minimizes the immunity of the patients and then making it more predisposed to contracting the infection, and then the events which happens after contracting are much more morbid than normal patients. So there's an analysis done in Wuhan, China. So they have found that the patients who have gone through the chemo and surgery, so these patients have correlated with the patients who contracted and who didn't have the cancer. So there is a significant change in the events which have happened in the patients with the cancer. That means to say that because of the underlying immune the events which happen or the complications which happen following the COVID-19 infections are considerably bad for the patient's outcome. Okay, when we talk about the radiation therapy, so the radiation therapy is being a loco-regional and then local or loco-regional, and then it is a non-invasive treatment. Non-invasive, what I mean is like physically we are not cutting or causing any damage on the surface of the body or anything. The rays enter but does the damage to the tissues, but it is very limited area, and then compared to the systemic treatment, so this modality is relatively safer, means less impact on the systemic immune system because we are treating only the small portion of the body. Again, you must keep in mind which area you are treating, because sometimes a large area is treated with a lot of bone marrow containing bones are involved, then again the immune system may be greatly compromised as well. So you got to keep in mind how much area you're going to treat. But generally it is bit more safer, I can say, compared to the systemic treatment with regard to the compromising the immune status of the patients. Why radiotherapy is so important is, at any point of time, a patient who is having a cancer, so they need radiotherapy in about 2/3 of the patients. So at any point of time during the cancer care, they need radiotherapy. Hence, the radiotherapy becomes an integral part of the multimodality treatment. So in some cancers, the radiotherapy is the primary treatment. In such cases, then it is very important to consider to treat or withhold or postpone or omit it. It all depends on the clinical situation. And okay, if we have a patient who is diagnosed to have a cancer, newly diagnosed patients, so the question arises, can we hold on, can we postpone? How to go about it? So this is an big question. Not so easily and in one you can decide and explain to the patients or make a decision by yourself to treat or not to treat. So there are some guidelines available, so which are devised by some of the oncology centers worldwide. So one of them is like in Ontario, a cancer care center has come up with some stratification of the patients. They have divided the patients into level 1, level 2, and level 3. So level 1, they say that continue the treatment. If COVID negative, on treatment, continue. If becomes positive, maybe you consider a short break depending on the patient's clinical condition with regard to the cancer and also considering the severity of the COVID infection. This is a very balanced decision-making process. This must involve the patient and then the patient's immediate attenders or the relatives to make them understand if we continue, what are the possible risks they can undergo. So that's a very critical decision to be made, taking patient and the patient's family into consideration and then proceed or not to proceed. And also in some patients who are highly symptomatic, like patients having a bone mets, having severe pain, and the painkillers are not working very well, and then patients have got a brain mets and then having headache and impending neurological problems. So, and patients who are having tumors which are bleeding, not able to control the bleeding with the conservative management, and then the patients also who are potentially curable with radiotherapy alone. So if you delay, probably the tumors may progress and then may cause the compromising their eventual outcome. So these are all the patients put under the level 1 and to continued treatment. So the level 2 are the patients who are requiring radiation therapy routinely in a normal period of time, like adjuvant therapies, and then patients not having very aggressive tumor, indolent tumors like low risk prostate cancers and benign diseases where radiotherapy also is being used, like craniopharyngioma, pituitary adenomas, glomerular tumor. These are all when radiation is to be considered. These are all the can you give a short delay or postpone the treatment by a few weeks without compromising their eventual outcome. So these patients are grouped under level 2. And then the level 3 is like either hold the radiation for a little longer period of time or omit these patients from getting the radiation therapy during the immediate course of the cancer care. So you can also consider other treatment if available, which are not so toxic to the patient's general health. So you need to consider all those things. So putting these patients into 3 levels, like major areas where what are the kinds of patients can be put under level 1, level 2, level 3 is like breast cancers, which is very commonly seen all over the world. So in level 1, you need to continue treatment is like patients with non-metastatic inflammatory breast cancer or locoregional disease, which is not responding to the systemic treatment like chemotherapy, hormonal therapy, or even the sometimes immunotherapy. So these patients needs to be considered to be continuing the treatment, considering the patient's comorbidities and then the other risks involved in continuing. So it's a balanced decision-making process. And level 3 are the patients who can be safely emitted the radiation therapy by the criteria set out by the CALBG and prime 2 criteria, like very early breast cancers, elderly ladies, and then the hormone receptor positive, and then good pathological prognostic factors. Probably you can omit the radiation therapy in such patients. And the CNS tumors, high-grade gliomas are very aggressive in nature, and also the spinal cord tumors, which can cause the neurological deficiency because of the small space there, and then the tumor growing and causing the pressure onto the nerves and may lead to a neurological deficit. So in such cases, the radiotherapy strongly needs to be considered because the tumors are very aggressive. And other benign tumors, which also can cause the neurological symptoms if not treated immediately, to be considered. But again, you have to look at the biology of the tumor here before you make a decision to proceed. The other tumors, probably you can prolong a bit longer withholding the treatment, is the low-grade gliomas. Maybe they are symptomatic but can be delayed for a little longer. And other cases where you think that a safer chemotherapy can be considered during this time to delay the radiation. Again, chemotherapy decision is made with the medical oncologist and the radiation oncologist, and then the family all sit together and have a discussion and then decide which way to go about. And other patients who can be safely delayed for a longer period of time, or even sometimes you may omit also, are like the tumors with very, very slow growing tumors like meningiomas, and then pituitary adenomas confined to pituitary, not causing any immediate effect, and craniopharyngiomas, and pilocytic astrocytoma, and the patients who have undergone surgery with, for the low-grade gliomas, and who may, in the other times, may require adjuvant therapy. In this particular pandemic time, you may consider to prolong little longer, or you may omit also with the careful monitoring of the tumor. Okay, and then other things like schwannomas, trigeminal neuralgias, you can consider to withhold. Then the GI tumors, usually the anal tumor, esophageal tumors, and the gallbladder. So these are all that tumors are usually symptomatic and then cause the obstruction. So delaying will worsen the patient's general quality of life, and then they will suffer. So, and also in cases where the rectal cancers, where they are inoperable for various reasons, one may consider to treat immediately. So other things which can be held back is like where you think that adjuvant treatment or neoadjuvant treatment is needed, probably you can hold on for a while. Genitourinary tumors, like curable bladder cancers, where surgery is not possible or is not done, and radiation is considered to be the primary treatment. And then the poor risk prostate cancers, who have not responding to the androgen deprivation therapy, and then the small cell type of tumors arising from the genitourinary tract, and the patients who are already on treatment with both the modalities of treatment, no need to stop the treatment, you just continue the treatment and then carefully monitor the patients as well. Okay, so the other patients who can be delayed a bit is patients who are already on hormonal treatment and then they are responding. Probably you can hold on for a while, and then once the situation dilutes or becomes a bit better, maybe you consider a bit later. And another important area where gynecological cancers like cervical cancer, endometrial cancer is a very challenging task in the developing countries, because the mere number of cases we have, and whether withholding the treatment will severely impact the total outcome. So here we have to make a very judicious decision, taking patient into consideration, discussing with them pros and cons of continuing the treatment. Like patients who are having a locally advanced cervical cancer, or patients have got a bleeding tumor and have a severe symptoms of pain and cachexia. These are the patients you still need to consider treating these patients. The only patients whom you can think of delaying a bit is like adjuvant treatment for the endometrial vulval cancer and then the cervical cancers who have gone through the surgery, but there are pathological factors making them to go for the adjuvant treatment. Probably you can hold on. So other cases where you can omit is like omit or delay for a little longer or prolong bit longer is like endometrial CAs, like stage 1B, 1B2. So these are the patients like you have to really think and see whether this adjuvant treatment is going to make a real impact on the overall survival. So based on that, you got to make a decision and see. You can proceed. Okay. Another common tumors are like a head and neck tumors. Here, the head and neck tumors, quite a few areas, radiation becomes the primary care, or the radiation is the sole modality with or without chemotherapy, concurrent chemotherapy. So in all these cases, like nasopharyngeal carcinoma, which is very prevalent in this part of the world. So, and if you don't treat, then the tumor may expand and then go into various directions, especially into the base skull, and then the involvement of the cranial nerves, and then going into the brain, which is very common. So in such cases, like you still need to consider continuing with radiotherapy alone or with concurrent chemotherapy. And some patients who have gone through the surgery for the head and neck cancers, other than the nasopharynx, other head and neck cancers, where the pathological features strongly suggest the immediate treatment to be done. Otherwise, they bear the high risk of recurrences. So you need to consider them. And sorry for the crowded slide here. So all other curative cases where you think that you can give some small doses of chemotherapy without compromising, greatly compromising the patient's immune status, you can consider induction chemotherapy. And sometimes very low grade tumors, you can postpone a bit. And then small recurrent tumors which are not causing the symptoms so much. So these are all the patients you can prolong a bit. And then the other things like where you can omit or you can prolong quite longer period of time, or like non-malignant tumors like lobus jugular tumor, and then the small basal cell carcinomas, and cutaneous non-pigmented carcinomas, keloids. So these are all the things you can prolong quite longer without, this will not have an impact on the overall survival. So lymphomas, role of radiotherapy is not so much in managing the lymphomas, because the systemic treatment is advanced so much and giving a good results. But however, there is a role for radiotherapy here. Patient may have a tumor in the mediastinum, which may be causing the superior vena cava obstruction or any obstructive features which is causing the radiotherapy to that area with continuing the systemic treatment will certainly improve the patient's quality of life and add to the total outcome. So in this particular patients like high-grade lymphomas, you need to continue and maybe consider to prolong or delay the treatment is like where you think that consolidation therapy would help the patients. Maybe you just withhold radiation for a little longer period of time until they become clinically better, or the situation with the pandemic improves a bit. And other tumors which are low-grade lymphomas, you treat or don't treat, usually the course of the disease is not so much altered. So you can withhold for a quite long period of time, or you can omit the radiotherapies. So again, in pediatric tumors, the role of radiation is not so much, but still there is a need for the radiation therapy in pediatric oncology patients. Okay, so all curable cases where you think that radiation delaying the radiation is not possible can proceed. So the one good example is like probably the retinoblastomas, which are not so good responding to the chemotherapy. So the next option is the radiation therapy, because it's an organ sparing treatment modality. You need to continue this treatment. And patients can be withheld or who are on chemotherapy or who are on interventional interventional mechanisms to delay the start of the radiotherapy, you can withhold. In other cases like prophylactic cranial irradiations and all that, you can omit. Sarcomas, again, they are very aggressive tumors. If it's an neoadjuvant or adjuvant, you can withhold for a while, because the primary treatment is not the radiation anyway here. So it's just an adjunct. So the primary treatment has to be considered depending on the severity or the aggressiveness of the tumor. The thoracic tumors, again, the role of radiation therapy is limited, because these tumors are basically systemic in appearance. By the time they are diagnosed, they are locoregionally advanced or metastatic diseases. The systemic treatment is the mainstay. So, however, the radiation therapy still can play a role in very early lung cancers, where surgery is not possible because of the underlying comorbidities or other possible contraindications. So then radiotherapy becomes the primary treatment with or without chemotherapy here. And even after the surgery, sometimes you may find that the patients may be having a poor pathological prognostic factors, where the adjuvant radiation therapy may be required. If not, then the patients may come back with the recurrent tumor in the short period of time. You need to consider treating these patients. And the patients who are having an single mets or patients who require a post-op disease without residual disease, just merely on very limited poor prognostic factors, you got to make a clinical judgment there, and then maybe you can withhold for a while. Another important aspect of radiation therapy is like radiation plays a very important role in alleviating the immediately distressing symptoms, so like cord compressions by the vertebral mats, and then symptomatic brain mats, and then the obstructive tumors, and causing especially in the superior vena cava obstruction. So the patients will be in great distress. So adding radiotherapy will greatly relieve the symptoms immediately, I can say dramatically. Okay, and then the tumors which are having an bleeding, which are not amenable to the surgical intervention or the conservative treatment is failed, so then you need to consider the radiation therapy immediately. Okay, so and where you can prolong a bit is like patients who are not having an obstructive symptoms, but they have a mets in all these areas, but they are not causing so much of a distress, where the painkillers may help them, and then the systemic treatment may delay their progression of the symptoms. All these cases you can consider to delay for a few weeks time. Okay, so should we postpone the treatment if the patient become COVID positive, or if the patient is already positive and diagnosed? So this is a real challenging task with the clinician treating and also with the patient. It's not that easy to come to a simple solution here. So because the patients already have a dreaded disease diagnosed to have cancer, which drains out the emotional, psychological, emotional, financial, familial, social, all aspects of the patient's life. So in this particular period, if they develop a cancer, it's very hard to tell them, like, look here, you got a COVID-19, we can't treat you, although you have a cancer. So it will have a severe impact on the patient's mind. And they are already grappling with this disease. And if COVID-19 is there, you can't tell them that, no, we are not going to treat you. So, which is which can have a legal implications if you don't treat and later on the patient progresses without having a severe complex complications of COVID-19, the patients can sue you as well. So you have to take a very judicious stand here. So whether the patient is having a COVID-19 positivity or you don't know the status, so every patient's coming for the treatment or to begin with to start the treatment, you got to have a good lengthy discussions with the patients and the immediate caregivers, because all must be taken into consideration and then you make a decision, because the treatment also can cause the immunocompromisation. So hence you need to tell them the risk versus the benefit. Only then you can make a decision and then go ahead. And a particular tumors, if there are alternate simple treatments are available, you can withhold for a while before you proceed to treat with radiation therapy, like the prostate cancers who are low risk prostate cancers or favorable medium risk prostate cancers. Probably you can use the hormones which are not so toxic, and the symptoms can improve with the hormones as well. So you need to consider all those things. And another option is, like, if you need to treat the patients where you have no choice, then probably you may need to make some adjustments in the treatments. Like probably you can shorten the course of the treatment, and so that the patients will have a lesser number of visits to the hospital, and then the dose per fraction although will be higher, but there is insufficient available data with many centers across the world that this treatment, shortening the course of the treatment, hasn't seriously affected the patient's general health. So keeping in mind all those things, you can shorten the treatment. But being in an oncology treatment, oncology caregiver, and especially in the radiotherapy department, because it's not just the patient and the clinician alone. In the radiotherapy department, apart from the clinician and patient, there are other people involved here, like the physicist who does the planning for the patient and then checks the quality assurance of the treatment. And finally, not to forget the radiographers who are involved in day-to-day treatment of the patients who are coming in contact with the patients every time. So you need to consider their health, and then
water needs to pay bill, you know that?
Hello? Yeah. Okay, so you need to consider all those things in the radiotherapy department. It's unlike the other modalities of the cancer care. So here it is a teamwork radiotherapy. So you need to consider all the people involved in the treatment here. So, however, when you are treating the patients in this particular time, especially if you have a positive patient, it puts a lot of burden on the treating team here. So the strict measures to be enforced, so like infection control measures as stipulated by the national guidelines or the institutional guidelines, you must make sure that all the things are properly followed, and you must prepare a workflow for this particular time, how to proceed with, and then the staff are educated, and then the patient also is educated how they must enter the hospital, and then the triaging guidelines to be followed. So strict infection control measures should be implemented, and then make sure that it is working well. And other aspects is like you can make some adjustments in the treatment planning and QA programs. Like how you can do is, like, you can minimize the treatment positions for each patient, and also you can avoid using certain gadgets during the treatment, because every time you use a gadget for every field, the radiographer has to go in and then insert the gadget into the treatment machine before delivering the treatment. So there is a longer period of time patient will be in the department, and then the radiographers will be coming in contact with the patients for a longer period of time. So such things can be avoided, and you can use you can avoid using the complicated treatment plans like breath holding gated techniques, and using some invasive devices while going through the treatment, like you use the rectal balloons to treat the prostate cancer to distance out. So these things can be avoided. And portal images can be taken and then remotely can be verified. Need not be going into the room every time and then exposing yourself or the staff going there. And then you can position the gantry positions in such a way that when the gantry is rotating, it doesn't hit the couch. So make sure that all these things are kept in mind while preparing the plan. And another thing is when you are talking about the targeted treatments for the, especially in the head and neck areas or the prostate, so you can avoid doing the more frequent CBCTs. You just do the KV imaging and then space out the CBCTs to make sure that your plan and then the delivery of the treatment is going hand in hand. And other logistic and ethical issues which come into the place here is, like earlier I said, if the patient while waiting, or the break is given during the treatment, and while waiting to restart the treatment, if the tumor progresses, so the patients can sue the hospital or the doctor. So this also kept in mind, and then during that time maybe an additional consent to be taken from the patients to safeguard yourself and also the hospital. So these are all the individual things each center and then each hospital has to come up with their own policies, and then make sure that all aspects are taken care, and with the adequate information given to the patients while they are made to wait. So some organizations, big organizations like European Society for Radiation Therapy, have come out with some guidelines, general guidelines during this crisis time. These are all just the guidelines, not necessary that they are binding on any particular institution. One should consider these things because these are coming from a big body in the Europe, taken input from the various major cancer centers who are treating a large number of patients. So it's a valuable input in making your decisions. So if possible, you can suffer from, you can postpone the treatment. They say that if at all possible, considering the biology of the tumor and then the patient's general condition and patient's willingness to hold on. So all these things to be taken into consideration. So, and if a patient is COVID positive or if he is suspected, so probably you need to consider interrupting the treatment if they are already on the treatment, because this will reduce the risk of exposing the other patients as well as your staff. And you should have a, if you are treating COVID-19 patients, you must have a very few dedicated people to treat these particular patients. And another thing is like, maybe a point may come that your staff are infected and then your working strength has reduced. So maybe you need to collaborate between the two centers or your nearby centers and then have a collaborative approach. If they need our assistance, we should be willing to extend our help in providing the personnel, or if we have a problem, we should be able to get the help from the other side. So these are all the mutual understandings between the nearby treating centers. You must keep in mind all these things, because you may end up having a significantly reduction in your staff because they are they're contracted while handling these patients. So what to do if the patient is already on treatment and then patient becomes positive, and then you may have to give a break. You have no choice because the continuing treatment may seriously jeopardize the patient's general health. So there are some papers which have been produced from previous natural calamity experience, like Hurricane Maria in Puerto Rico 2017. From that, they have seen the impact on delaying the treatment and then how these treatments can be compensated. From that, can refer to this paper and get some idea how to compensate for the delay and adding the dose to their total treatment. So this is again is the same thing what I have talked earlier, like either to be stopped or interrupted, and or to continue and then finish the treatment. But in this process, what you have to do is you are not alone in this decision-making process. You must always consider the local health authority guidelines, keeping in mind all those things, then you make a decisions. Another thing is like if the patient is infected, so if you have a large department and then you have enough manpower and resources, maybe you can dedicate one machine for treating the COVID-19 patients, and then you must have a dedicated entry exit points, and then their movements guarded, and then the set of radiographers are designated to treat those patients with regular monitoring of your staff as well. Okay, it is easily said, but it's very hard to achieve it even in a bigger centers. So to put everything in a nutshell, the summary of cancer care, the COVID-19 is a pandemic disease which has caused an international emergency. So more so with the cancer patients, because they are already frail and then they are having lots of other problems related to the cancer, continuing treatment may severely compromise their risk of infecting the disease. So here the decision-making process is a very complicated one, but you got to make a judicious decision here. And also these patients, cancer patients, are usually old age. They have other comorbidities, which also you must keep in mind before you start the treatment. And you must make sure that the patient's frequency to the hospitals as minimal as possible. Choose a protocol which helps you in making this adjustments. So the most important thing is the risk of cancer patients getting into this pandemic situation. So this must be clearly explained to the patient. You must have a lengthy discussions before you start. And wherever you think that you can defer the treatment for a little period of time, you should give them option and then delay the treatment. And again, when it comes to the radiation treatment, the dose you can de-escalate, or you can reduce the number of fields and then the number of fractions, the techniques, all these things can be modified a little bit without compromising the outcome with this treatment. So this is with the treating clinician. So he can make a decision and then either shorten or reduce the number of fractions with increasing dose without compromising the total outcome. And even though we do not have an, sometimes what happens is the evidence-based medicine. So sometimes you may not have the level 1 and level 2 evidence, but still you can use certain de-escalation strategies. Means de-escalation is the reducing the total dose of radiation to be given to that particular tumor with some trials which are backing up. But they may not be level 1 and level 2. But in this situation, it's something is better than to fall back upon than nothing. Okay, so and treatment technology should be as simple as possible, and maybe you can use the stereotactic radiations. So these are all the measures you can take. If upfront positive, consider the tumor biology and burden of disease and the symptoms, and if you treat, what are the possible toxicities, then you make a decision to treat or not to treat after carefully and exhaustively discussing with the patients and then the immediate caregivers. And if patient becomes positive while going through the treatment, the balancing between continuing treatment and then the possible severity of COVID-19 complications, this has to be balanced and then make a decision accordingly. So, but one thing must keep in mind is less might be better in this particular time when you are considering the cancer therapy. And another thing is you keep in mind all the available guidelines, like global WHO guideline, your national guidelines, or your society guidelines. All these things to be kept in mind and then make sure that all these things are in place when you are treating the patients. And the access to the radiation department to be minimized, kept shorter, and then a less number of times. So by reducing the number of fractions and then shortening the daily treatment time, you can achieve this. And make sure that the hospital will have the proper triage team before they allow the patients to get into the radiation therapy or the cancer department. So anything you notice in the triage which is unusual, then immediately the treating oncologist should be alerted, and then the decision to be made whether this particular symptom is related to the COVID or the cancer, anticipated cancer thing, then you take a call and then continue. And institution must follow all the sanitization procedures, not just the institution, everywhere, every place is being following this sanitization, which is not something new to the hospital or the oncology department. This is a must for each and every person wherever they goes. And maintain the social distance, and make sure that you have a good communications with your patients and then the immediate caregivers, that is the family members and others. And any new information is available to you, you must share with your patients, make them understand, which becomes much easier for you to continue the care. So you have to give as much as possible the knowledge and the information you have with the patients, so that it becomes easier to proceed or withhold treatment or omit the treatment. And you shouldn't forget your staff safety. It's not just the patient and then yourself, your other team members like your physicists, your radiographers, and then your clinic aides. All the people should be adequately trained, and then enough knowledge is given to them, what is available with you. And you should make sure that the hospital or the clinics will provide them the required personal protection equipment which is necessary, especially if the patients are dealing with the COVID-19 positive. You must make sure that the staff are getting the proper PPEs and make sure that they are protected. Now, how can technology help us in this time is like artificial intelligence based analysis of the imaging. Like you may have some AI programs which may help you in diagnosing whether the patients have got a pneumonia or whether the patient has got any other problems. You can do the imaging, and then without the clinician being involved, AI-based program can be used to detect earlier before the patient becomes symptomatic. And you must always encourage patients to keep in touch with the team, either through video or the teleconsulting, which is becoming a norm now, and which is going to be the normal way, which is a part of the normal way of consultations with the clinics in due course of time or in future. So the teleconsultation is going to be with us, not just the oncologists, in all fields of the medicine. So you must encourage the patients to have a teleconsultations whenever it is necessary, and not to hold the information and the information regarding their suffering and the symptoms. And maybe in due course of time we will have more apps available, and then things will help us, and which will help in mitigation and containing the COVID while continuing the cancer treatment. Let's hope we will have more technology assistance. Okay, with that I end my talk on the radiotherapy during the COVID-19 pandemic. I just want to bring to all of you that we are running a clinical trial in patients who have got a metastatic or recurrent lung cancers, which are non-small cell in type. We are doing this trial as a part of the multi-institutional globalized trial. We are part of this team, and then the trial name is Samson 2, and the patients will get benefited because we are giving the standard of care chemotherapy with a targeted therapy of proven value, and another one is the biosimilar one. So the patients are in no way compromised in getting the treatment properly. So this trial we are running, and then any of your patients who think may benefit from this, you can refer to either Nilai Medical Centre or the Cancer Society, so that the patients can get in touch with us, and then we can have a word with the patient, explain to them in detail whether they are eligible or not. If they are eligible, what is this trial about, how they can be benefited, and then also all the detailed discussions can be held with your probable patients. We can help them out. This is to help the patient because the treatment is expensive. Cancer care is an expensive affair. So wherever possible, these trials can help the patients in terms of overcoming the financial burden. So this is just a request for all the members in the room. So if you come across any patients like this, you can refer to us. And another thing is like Nilai Medical Centre and then the National Cancer Society is a collaborative effort. So we are, whenever the National Cancer Society refers the patients to our center for radiation therapy treatment, which is an expensive treatment as well. So Cancer Society and then the Nilai Medical Centers are giving them an financial assistance to lessen the burden on the patients' spending. So both Cancer Society and Nilai Medical Centers are helping the patients to minimize this burden and keep their cost of treatment as minimal as possible. So those patients also can be referred. We can help them out. It's not just the hospital making money. We want to help the patients also. It's our social responsibility. So if you have any patients who think they need this treatment, but they are unable to proceed with the treatment for the sake of finances, we can certainly help them. So we have certain funds allocated from the Cancer Society as well as from the Nilai Medical Centers. We will try our best to help the patients in a needy moment with regard to the finances. So with that, I will end my talk. Thank you.
So thank you very much, Doctor. That was a really very thorough kind of coverage of the entire scope of how to kind of segregate and perhaps categorize what patients in terms of priority or radiation therapy during this COVID time. So for those who are with us, can I give you the first code word, and then I'll just give Dr. Chandra a couple of minutes to maybe get a glass of water, and then I think Dr. Chandra will be very happy to take some questions as well. We've got quite a few interesting questions, Doctor. So just to share, the first code word is brachytherapy. So the first code word is brachytherapy. So so that's that. And then if Doctor is able to take some questions, we have a question on some of our prostate cancer survivors are experiencing rising PSA levels despite radiotherapy treatment. So the question is, can any of these radiotherapy treatments that you mentioned be used to manage rising PSA? This is, I think, from one of our attendees today. Over to you, Doctor.
Yeah, Murali.
Oh, sorry. No, I was saying there's a question. So there's a few questions, Doctor. The first question is, some of our prostate cancer survivors are experiencing rising PSA levels despite radiotherapy. Can any, would you be able to share on whether any of these radiotherapy treatments that you spoke about today, are there specific ones that can be used to manage rising PSA levels? Or, I mean, how related are they?
Yeah. Okay. If they have been already treated with the radiotherapy and then they are facing this PSA level rising, so you need to re-evaluate the patient first before you make a decision on the what kind of a treatment they would be requiring and will benefit them. Like with the rising PSA, maybe either because of the progression of the tumor in the prostate itself, which has not responded to the radiation, or there may be metastatic disease elsewhere, subclinical disease. So you need to find out that, and then if you find that there is a disease elsewhere, the metastatic disease, and the patients who have been treated earlier with only the localized treatment, you should consider treating systemically. So here the great majority of the patients will be responsive to the hormonal treatment. So if it is an subclinical and then asymptomatic, that is only the biochemical relapse we say. If only PSA is rising, patient doesn't have a symptoms. In such situations, the hormonal therapy will come to the rescue, and then you can start safely that one.
Right. Okay. Okay. So I think the next question is very kind of connected to what you finished up with just now, doctor. And the question is, as a cancer survivor, we are of course now very worried to go to hospitals and even clinics. So what is your view of having virtual meeting with your oncologist or your treating doctors? And the sub question for that is, what do you think if this is going on? It can be a standard of care. How do you think the charges should be put if you have any ideas on this?
Okay, the first part of the question is like, if the patient is experiencing any symptoms, so they can always get in touch with us if the symptoms are mild to moderate and which can be managed with the simple analgesics which are available over the counter. They can take that and then get in touch with the treating oncologist, and then see whether the oncologist makes a decision whether he needs to see the patients or just recommend certain medications for a little longer period of time. And if it is for the survivors, if it is a routine follow-up, we call the patients for the routine follow-ups, like once in 3 months, once in 6 months, depending on the disease and then the possibility of relapse and the behavior of the tumor. So we space them out for the follow-ups. So such follow-ups can be spaced out. Unnecessary follow-ups can be, I wouldn't say unnecessary, you can space them out. No follow-up is an unnecessary one. You are calling them for follow-up for some specific reason.
Purpose, yeah.
So such things, like if the risk is less, then probably you can give a little longer period of spacing. So, and you can space them out, and then certain visits to the hospital can be minimized. But during that period of time, if the patient experiences any kind of a symptom, they can have an teleconsultations, or even if they have like nowadays WhatsApp, everyone got, and then video calls are there, and then everybody is easily accessible. You can use those tools and gadgets, and then you can discuss with your problem. I'm sure all the treating oncologists are obliged to do that. I don't think anybody is denying for the patients this particular option. And another thing is like the charging issue is basically, it is an a regulated move which is taken by the medical association and also the hospitals together. So they are coming up with a policy like how the charging should be. Like MMA, you have a MMA schedule which defines the charging pattern, but this particular situation was not there in the past, so the teleconsultation was not included. Probably it will be included, and then the government will come with the policy, and then it will not be expensive than the routine clinic visit consultations, which will be, I'm sure, will be lesser.
Right, right. In a specific context, doctor, in terms of your own experience, how are you dealing with one, if it is a patient who's already on a follow-up, so it's a known patient of yours, how are you spacing them out? Are you saying to them, if there's it's a 3-month appointment, are you all calling them to tell them, look, let's push it to 4 months? Or what is the current working practice?
Yeah, some of the patients who have a less risk of recurrences, like you know the disease, what you are treating, and then what for you are calling them, like thyroid patients, differentiated thyroid patients, you call them to check for the what you call T3, T4, TSH levels, whether your thyroxine dose is adequate or not. Another one is you are doing the thyroglobulin, which is a marker to see the recurrence. In such situations, what we tell the patients is, you do the investigation with the local lab, nearest local lab, and then send us a report. So through the mail or through the WhatsApp, we communicate, and then we tell them to avoid that particular visit. Or if patient is in a middle range where you also have a risk of tumor coming back, then maybe instead of 3 months, you can put it 4 months or maybe 6 months.
So would you advise?
Also, you got to check with the patients, like other associated symptoms, like the patients may be losing appetite, losing weight, but they don't have any cancer symptoms and all that, probably you need to see them one. No, it depends on the clinical situation. You cannot have one policy for all the patients.
Yeah, for sure. So would you advise then that patients who, let's say they've been given an appointment and their appointments are starting to come up now, would you suggest for them to at least make that one call to the doctor or get in touch with the clinic or the clinic nurse to see, hey, do I need to come?
No, we are contacting all our patients who have been otherwise scheduled, and then our clinic staff will call them and then find out how they are keeping, they are well or not, any problems, if they are
good, that's lovely,
good health, and then no symptoms and all that. We are postponing their appointments, and if our clinic staff is not satisfied with what the patient is telling, and then they cannot answer them, then we will talk to them. We will talk to them and then make a necessary judgment whether I need to see them or can space out.
Okay, and really I feel this for those who are in the session, I think this is a good policy that I think we should all kind of institute and practice, in the sense that with our patients, as Dr. Chandra and his team are doing, perhaps it's good to reach out to our patients rather than to have them be in a bit of a limbo or confusion as to, do I come in for this appointment, do I not come in? And we get quite a lot of queries about that as well. On a regular basis, do I go for this appointment, do I not go for this appointment? Because some of the more stable patients, they're already on follow-up, which are 6 monthly or 4 monthly. So in that case,
such patients can be deferred the follow-up for a little longer period of time, no issues. But
that's right.
Best is to talk to the treating oncologist or treating doctor, rather than making their decisions on their own.
Right, exactly, and that's, I think, the important message. Another question, doctor, is okay. So this is quite a long one. From the hurricane experience that you shared with us earlier in your slides, it would seem that delaying the radiotherapy during COVID-19 might worsen outcomes. But at the same time, you also share with us the slide on the Chinese experience, where it looks like outcomes with radiotherapy are worse during the COVID pandemic. So what would really be your kind of top insights or advice to patients for whom radiotherapy is planned? Do you, as a general thing, do you think they should have it?
Yeah, this is a very tricky situation. So one side we are saying that you cannot delay. Another side you can saying that maybe you can. This is a very risky decision-making process. It's not a very simple one. So that's why, like, on a patient-to-patient basis, you got to have a lengthy, detailed, informative, educative discussion with the patient, and also you must keep in mind what kind of tumors you are treating. Are they aggressive in behavior, and what is the biology of the tumor, and where is the site of the treatment? If you don't treat, what's going to happen? If you treat, what benefit you are going to give without so much compromisation on the pandemic. So you got to make an balanced decision here. So it's not an easy thing to do unless the patient understands whatever the decisions you are collectively making it, then you can proceed with that treatment. It's not a simple thing. Like, of course, the one experience which comes here is like they just analyzed. It's not a recommendation. That's how they said. Looking back at the patients who had a cancer and then the patients who didn't have a cancer, how the events took place with respect to the complications happening due to the COVID-19, which was worse than the cancer patients. The basic reason he is saying is because of their immune status, the events which have happened, which led to the worst outcome of COVID.
Right, and I think one of the interesting things that I think you pointed out as well, and which I was also looking up at in the ESCO guidelines, is the fact that when you compare radiotherapy to systemic chemotherapy, there seems to be a lot less risk actually from doing radiotherapy. During this time, in terms of exposure.
It's a generalized statement again, but you must keep in mind which part of the body and how big the area you are treating. So if it's a large area and then the marrow containing spaces you are treating, large marrow containing spaces, then you got to be careful, monitoring of the blood counts and the patient general health, and then the look for the side effects, acute side effects. So all must be kept in mind.
Right.
Yeah.
For sure, doctor. So in terms of
there is sorry,
you were saying, doctor.
There is one question here on, I can see, is like, can lung cancer just be treated by radiotherapy alone? By
Yes.
Stella,
Right.
which has been catching my eye quite often.
Okay.
Okay,
Please
I just
go
want
ahead.
to respond to that.
Yeah.
Okay, very small number of patients who present with a very early stage disease, so who are technically operable, but because of certain reasons like comorbidities or whatever the reason, they are not ideal candidate for the surgery. So then the radiotherapy alone is the standard of care. Yeah, see, radiotherapy and then the surgery are similar in nature. The surgeon will cut and go in and take out. We don't cut, we send the radiation and do the job and finish it off. So that's similar in approach. But the thing is, if surgery is possible, best is to go for the surgery. So only if surgery is not and a good option, although it is indicated and good, it's not possible rather. So then radiotherapy alone can be used to treat. Like stereotactic body radiotherapy has helped in focusing the tumor with a large dose of radiation, achieving almost the similar rates as the surgery. Still can be used
Right.
alone. Yeah.
I think that's one of the kind of important messages perhaps to share with our colleagues, which is as Dr. Chandra is saying, I don't think radiotherapy is an either-or option. So it's not like you have to do surgery or you have to do radiotherapy. You have to do radiotherapy or you have to do chemotherapy. I think it's an idea of appropriate use for the appropriate situation.
Yeah. See, currently the cancer care is not a single man's involvement in the treatment. It's a multi-modality. So ideally, before you start your treatment, all the multi-modality team has to get in and then discuss before you make a decision to treat the patients, like medical oncologists, surgical oncologists, radiation oncologists, radiologists, pathologists, all will sit together and then discuss, and then you must make a decision how to proceed and what will be the good treatment, keeping in mind all the available evidences. So it's a multimodality treatment. Cancer care is a multimodality treatment.
Right. Moving right along that arc, doctor, there's a question on, should radiotherapists who, and I think that applies to kind of the radiation oncologists as well, facing these challenges during COVID-19, be in discussion with ethicists or medical defense advisors? As you were saying just now, when you I think this is in context to
legal ramifications. Yeah, that's why I said, like, in this particular time, probably you may have to devise your own additional consent form. So like this all been explained to you, and then considering your clinical conditions, continuing the treatment or withholding the treatment decision is made, and then the implications of that may be so and so must be enlisted. This is an additional step you need to take. And then if you have the resources available with you, maybe involve your legal advisor or ethicist, or you have a body within your hospital, all must join together to devise this consent form and explain to the patient also. It's not an unilateral one. Oh, I got a consent, I got it signed, everything is covered. No. Despite all these things, you must have a discussion with the patients, make them understand, give them enough time to make a decision by themselves also, not in a rush to sign the consent form and then proceed. The patient also to be safeguarded, and then the treating team also to be safeguarded.
Okay, got it, doctor. There's one more question actually, but just before we go into that, I was going to ask you, how is it in Nilai Medical Centre in your own setting? How are you kind of, could you share with us a little bit of what are the processes you've put in place to kind of triage patients? You were saying earlier for COVID-19, what are the processes for them when they come into radiotherapy? How are they being safeguarded? How is the staff being safeguarded?
Yeah, okay. Generally for the Nilai Medical Centers, only one entrance is made available for all the people, patients as well as for the staff. So all must go through the triage, including the staff, every day. the temperature checking, and then the patients who are coming for the first time or the patients who are on frequent visits also. So they are given a form which is given, which has got a questionnaire and which asks the history of their exposure to any COVID positive patients, their travel history, and then their family members, anybody having any flu-like symptoms and all that. Those questionnaires to be filled up, and then our triage team will look into it and then check the temperature, and then give them the hand sanitizers and all that, and then make sure they are wearing the mask, and a person will escort the patient to the designated place where they need to go. They cannot loiter around, and then quickly finish their designated treatment or the follow-up or the purpose of visit, and then get out of the hospital as early as possible. So keep them as short as possible within the hospital. And patients who are coming for the radiotherapy, like those who are already on treatment, like every day they also, the temperature is measured, and then our radiotherapy staff will be questioning them like a casual talk. How are you feeling? Do you have felt any feverish experience, or you have any flu-like things? So day-to-day basis, we are monitoring every patient's, even though they are already on the treatment, because while traveling, while coming any day, anyone can get get this infection. So we have educated our staff, and then they are careful, and then anybody who's having any suspicion, then the clinical team is alerted, and then we make decisions. Like one patient I had who had the fever, who was referred to me for the further treatment because the patient had failed hormonal treatment for prostate cancer, which was metastatic. But when he came here, he had a 38.6 temperature. So then I went down and talked to the patient's immediate relative, that is the son, and told him, so these are the reasons I think he should go for the COVID test before we start the treatment. So the son was very understanding, and then he agreed, and then they did a COVID test. And then the following day only we took him in because the COVID test was negative. So any suspicion arises, we will take adequate measures to make sure the proper care is given, and then the testing is done.
Okay, got it, doctor. Now, just moving a little bit to another kind of segment of the population. How about people who have completed or who are undergoing radiotherapy during this time, and you know, when they go back home, what is the advice that you would give in terms of for them to lower their risk of exposure?
Generally the patients who are on the oncological treatment, so any kind of a treatment is further compromising their immune status. So we generally tell them, like, one is the personal hygiene, and then the second thing is not to go into a crowded places or dusty places, and then exposed to the larger crowd, social gatherings, and all these things to be minimized. So this is emphasized more and more at this point of time. So we tell them don't to venture out unnecessarily, and then don't go in contact with anybody having any kind of an infection. So whether it is a symptom of COVID or not, we tell them stay away from the unhealthy people. So we are emphasizing more on this, particularly this pandemic period. Yeah,
that's true. Well done. Thank you very much for kind of strengthening that message, doctor. Because I think quite a lot of us actually, as the cases begin to come down, whereas it's getting a little bit more relaxed.
So giving us a feeling of temporary relief.
Yeah. So I think I need to be reinforce that message. There's just one more question, doctor, which may be of interest. It says, looking at the Ontario data as applied to the Chinese paper, was the Chinese patient population really heterogeneous in terms of tumor severity or risk? I think what our colleague is trying to assess is whether all these different type of cancers, they have different types of risk in terms of exposure and infectivity of COVID.
I mean, we cannot say that cannot make a generalized statement here saying that the cancers are different in different this thing. Of course, the chances of a particular race getting a particular diseases is a bit higher among them. The reason for that is not very crystal clear yet. These are all some hypotheses saying that like the what do you call Oriental descendancies have got a higher probability of getting a nasopharyngeal cancers and all that. This is again, it is based on the Epstein-Barr virus infections. So it's quite common among this particular group of people. So you see the more risk of them getting an nasopharyngeal cancer. Similarly, in the blacks, especially American blacks, the prostate cancer is more among them compared to the Caucasians. Again, it may be because of the hormonal status there, and, so it's like that.
Right. So, but in terms of type of cancer, doctor, there's really no information, right? In the sense that, oh, I have lung cancer, I'm at higher risk for COVID. Or, I have prostate cancer, I have a lower risk for COVID. I don't think we're seeing that kind of data anywhere, right?
Again, it depends on like if you look at a cross section of the cancer patients, so compared to the normal populations, they stand a higher risk compared to the normal population, because the very fact that the tumor has developed in them is because their immune system has failed. Means it's compromised, not totally failed, compromised. Hence the cancer got upper hand and then it's growing. So they are at a higher risk. From some studies, they have said that the risk of them getting a COVID compared to the normal people is twofold.
Okay. Okay. So what is this? I am waiting to see if we have any more questions from any of our colleagues. Just again, a little bit of kind of housekeeping. If you have any more questions for Dr. Chandra, that would be helpful. For those who need to claim your CME points, your first code just now was brachytherapy. In the email that we sent you to confirm your attendance for this seminar, we've sent you the link for you to register for your CME points as well. So please feel free to do that. And you have to put in 2 code words. The first code word was brachytherapy, and the second word that I'm giving you now is stereotactic. So we've kind of kept true to the spirit of Dr. Chandra's lecture. So the second code word is stereotactic. So you can put in, I mean, I don't think we're too concerned about how you spell it, but the word is stereotactic. So those are the 2 code words. Now, if we have no questions remaining, please allow me to let Dr. Chandra give a few kind of closing insights that might be of importance for us to take home out of today's session. Doctor, if I could invite you to kind of give us 1 or 2 take-home messages.
Yeah. Okay. First and foremost is like this is an international emergency, the pandemic. So the patients who have been recently diagnosed or who are going through the treatment for the cancers and all that, not to panic, but be extra careful and then discuss your cancer, your treatment, and then your problem with your treating doctor, and then get information and then the knowledge, and then discuss your concerns and then proceed with your treatment. Just because it's a pandemic and then you got cancer, you got to hold on for your treatment. No such thing. You still can continue your treatment, but the decision making process involves both patient and then the doctors. After knowing the full history by the patient to the doctor, and then the doctor's explanation and all that, if the patient is satisfied, and they can proceed with the treatment. Don't be hiding for your treatment because it's a pandemic. So because the cancer also is a deadly disease, so if not treated can compromise the outcome. So go and discuss with your doctor. Don't make independent decisions and then stay back.
Yeah. This is what Dr. Chandra is saying is especially more relevant because as we can see with the kind of end of the CMCO and things returning to more and more normal, your exposure in the general community is not going to decrease. But at the same time, I don't think we're looking at this disease being entirely eradicated. I'm talking about COVID-19 in the nearest future. We're looking to have to look at living with this condition for perhaps about a year or so until we get a vaccine or we get some kind of successful cure. So at this time, it's really crucial for cancer patients or people who suspect that they might be having cancer to actually not stay away from the system, but rather to have that discussion with their clinical treating consultants, their team, so that a joint decision can be made together in how to manage your treatment. And I think most importantly, Dr. Chandra has passed the message to us today that, look, radiotherapy at this time is still relevant and it's quite safe. And no one is really going to be throwing radiotherapy at you without actually assessing to see what are the benefits versus the risks of actually getting radiotherapy at this time. I think, again, the go home, the take home message is that you need to have this conversation. I think Dr. Chandra and I think all other clinical oncologists in Malaysia are already having that kind of interactive session where they are open to you, calling them, speaking to them, and finding out how to move forward. So the important thing is, as Dr. Chandra says, don't stay and hide at home alone. The idea is for everyone to get out. So as fellow professionals, we really would like to kind of ask you to push on this message to your patients as well. And let's try to not keep the second tsunami after COVID be another cancer tsunami. I think that's really critical. So just to kind of wrap up, once again, on behalf of the National Cancer Society Malaysia and perhaps the Medical Association as well, the Malaysian Medical Association, we'd really like to thank Dr. Chandra for taking his time and giving us a lot of really valuable input this late morning into the afternoon. Thank you so much, Doctor. We really appreciate it. And to Nilai Medical Centre as well for kind of taking us on this collaborative journey together. So what is this? The session is being recorded. We'll put it on YouTube for you all to share and perhaps rewatch and garner some more insights. Other than that, I think there is nothing much. Thank you so much.
I want to make one disclosure, Murli.
Yes, Doctor.
Our marketing team has helped me in preparing these presentations. Mine was more of wordings and then the theoretical part. They have been really helpful in making it a little bit more diagrammatic and making it more interesting. The marketing team led by Ms. Michelle and also my other colleagues, Dr. Khanna and our radiographers and all helped me in coming up with precise presentations to maximum possible limits. So I must thank all my colleagues and then our marketing team and then hospital, and greatly I must thank your Cancer Society and yourself giving us an opportunity to share some knowledge which we have already have and make other people's concerns dilute a bit. Thank you so much.
Thank you so much, Doctor. Have a nice weekend, everyone.
Thank you.
Goodbye.